So with no further ado, I will also introduce to you an esteemed international colleague, Dr. Peter Phiri, arriving here from the University of Southampton, the United Kingdom. Alors, Dr. Phiri is a visiting academic within the Faculty of Medicine and the School of Primary Care, Population Sciences, and Medical Education and Research and Development. He is at the Southern Health NHS Foundation Trust, and he has been in that role since 2015. So based in the Tom Rudd unit of clinical trials facility, Dr. Phiri has a wide range of clinical research experience of successfully designing, setting up, and managing clinical trials within the field of mental health and psychotic conditions. So today, Dr. Phiri is going to be speaking of the cultural adaptation of a CBT for psychosis intervention working with diverse communities. On va avoir une discussion par rapport à une adaptation culturelle d'un outil sur le CBT pour les patients vivant de psychose. Cette intervention sera en anglais. Alors, si vous n'avez pas vos écouteurs, profitez pour activer vos écouteurs ou obtenir vos écouteurs. Dr. Phiri, thank you for your time today.
Good morning, and thank you very much. Just really, once again, thanks, Daniel, for just this amazing piece of work. And I think, just really thought that, we can never be silent. We know what happens to a tumor that is not diagnosed. It grows and it kills. God has given us the voice, just like all the activists and everyone else that's gone before us. We're standing here today because someone raised their voice. And once again, we're grateful, the Jews and the team for putting this platform, because it is another platform where we have these conversations and have this discussion, and we get challenged, but we build on, and we keep on building on. The enemy will always try to divide us, but if we recognize their strategies, we take a step back and work together to do this. So hopefully, once again, just within this short time, I'll probably talk about cognitive behavioral therapy, CBT, talking therapy, which is widely used, and really focusing on its cultural adaptation for psychosis, but equally this can apply to any evidence-based interventions. And I think this really ties up nicely with some of the challenges that have been talked about throughout the conference, but also looking at some of the interventions that we then begin to utilize and apply to address some of these things. And that's just an overview of what I'll hopefully try and cover through. So a lot of things I'll probably speak over, but there will be the slides, and also hopefully this would be an opportunity for us to then interact, converse, and or collaborate. Always interesting, just as a starting point, to think about the role of globalization. What it has given us as an opportunity as a human species to really celebrate our diversity. Oftentimes, people get threatened by what they don't know, but actually, when you get to know someone, you really begin to enjoy the diversity that we bring as a peoples. One of the things that I always encourage people to think about, once again, celebrating like joy and pride, is about our individual uniqueness. Now let's get to say, there's only one of you in the world, over probably 8.9 billion people. There's only one of you. Yes, you might have a twin, but still you're different. Might have a doppelganger, but guess what? There's only one of you. You are unique. Celebrate your uniqueness. Enter a room, any situation that you're in, chin up, shoulders up. I am different. I am unique. Don't try and be like someone else. Don't speak like someone else. Be you, value you. That identity is very important. It's what then allows us to function at our maximum when we are true to ourselves. I think that's always important, but it's also something good for our health and well-being, and also something that facilitates in allowing us to be who we are. Throughout the conference, probably we've had whole themes around embracing diversity, fostering an open-minded attitude, And I think, most important thing is about us as individuals, whatever race, ethnicity, or color we are, developing self-awareness, reflecting on our own selves, reflecting on our attitudes about the other, identifying those blind spots, identifying our biases, but also thinking about how do we address that. As human beings, we all have got biases. Especially when you're working in healthcare, you come in with your baggage of biases, sitting in front of a patient. How do you know that you're not transmitting those biases to the patient? As healthcare professionals, we're often in a position of power. I see the world through my lens. And we see the power dynamics that at play when we're treating patients, whether you're in psychology, in medicine, in social work, whatever area you are. Very, very important to understand that. But equally, it's important, just like this conference, to promote discussions about diversity. Its benefits, very, very important. In addressing fears, biases, prejudices, but really focusing on strengthening an open-mindedness that allows us to accept our differences and accept different perspectives. And finally, to commit to embracing this diversity, celebrating it like this conference, which is really, really amazing. Encouraging open dialogue. It's very, very healthy. Challenging biases, but promoting understanding and empathy. Really, really important. And I think if there's anything I can confirm that this conference is promoting and facilitating that, and thanks to the organizers for that. So oftentimes I get the opportunity as a researcher to travel around the world. And most recently I was in New Delhi, and I went to the Taj. And it was something that's really interesting. When I just observed the Taj, I noticed that the pillars at the end were leaning outward. And so I asked one of the guides, why are they leaning outward? Because there's only one leaning tower of pieces, which is just leaning. And what was interesting, he said to me, the Mughal emperor, was aware of his environment. So he thought, well, if there's an earthquake, I don't want the pillars to fall in and destroy the mausoleum. So what he did, it deliberately built the pillars leaning outward. I was thinking, wow. So back in the days, these guys were actually understood their areas. Actually, so they developed something being adaptive to the areas. Once again, know who is in your backyard, know your population. Do you know the population that you treat? Do you know the localities? And I was also curious. So he said to me, can you see those symbols at the top of the dome? I said, well, I can see them. I said, I can recognize one, the crescent moon. I said, well, that represents Islam. And he said, how about the other three circles or something? Well, I'm not sure. He says, well, the next one is Hinduism, Christianity, and Buddhism. I'm like, wow. And I said, why did the Mughal have that on the mausoleum? He says, well, that's what inclusivity is. When you're inclusive, guess what? No one else will come and attack and destroy that building. And guess what? That building is still standing there as it was on the day that it was constructed. Once again, the power of inclusivity. So oftentimes we talk about cultural competencies and so forth, and you hear these words interchanged all the time. What do they mean? What does that actually mean to you? Once again, as life is, there's multiple definitions of things, but really cultural competence is the ability to understand, appreciate, and once again, effectively work with individuals from across diverse communities. What does it involve? Just like knowledge mobilization through workshops and research in other areas, is really knowledge acquisition, and also developing skills to navigate and often really, really messy spaghetti cross-cultural interactions. Very, very messy. And it's complex. Okay. And I think it's important for us to understand that, but also it's very sensitive as well. And also it's oftentimes, when we are talking about stereotypes and also trying to avoid them, oftentimes we end up falling into those, even though we're trying to avoid them. So it's again, just being mindful of those things. But I guess the most important thing is that it involves cultural awareness, cultural knowledge, and there's different ways. You don't get that from textbooks. Now, I can teach you about culture and everything else, but there's some things that are innate that basically are not in a textbook. Some nuances that really you can only understand when you're immersed and engaged with the communities. And it's not just a one-off thing that you just visit the community over an event and think you figure them out. It's an ongoing thing. It's an investment. So if you want to really engage with communities, it's not just a one-off. It's not when the grant ends. It's what really happens after the grant ends. How do you engage communities and really, really engage in those real cultural encounters? So just briefly, really just about evolution of CBT. I'm just going to put it down into waves. The first wave was really, back in the 70s, people like, John Watson, Skinner, looking at, classical and operant conditioning. And then they really set up the groundwork of cognitive behavioral therapies. But then the second wave was really the bring about of the cognitive aspects of this. And these were people like, Bandura, and also people like, Lazarus on cognitive restructuring. And then later on, really Beck's when they brought in the cognition into the behavior. And then you look at the third wave, is we're looking at, kind of mindfulness-based type interventions. And you've got some of the leads like, John Tisdale, Adrian Wells, talked a little bit on compassionate mind and others. And I often wondered, would fourth wave be cultural adaptations or indeed be digitalization of our evidence bases? Nowadays, there's, CBT, people using virtual reality, using boards and apps and so forth. But oftentimes, where are adaptations when you're working with groups that oftentimes have not been included? So this is one of the latest panoramic systematic reviews, basically a meta-analysis of meta-analysis. This was done by Fordham and colleagues in Oxford in 2021. What was interesting, so really they just looked at all the evidence of CBT across all populations. And really what was interesting, so they looked, I think, over 494 reviews. The evidence showed much of them were more on adult populations, and very, very small evidence within adolescents, which means like there's another gap to look at. But I thought what was really scathing from my perspective was that there were only 45 studies from the African continent. And this wasn't just Africa. So this was really being shared between Asia, South America, or Africa. And this is the evidence base that was being pulled. I was thinking, Africa is probably one of the biggest continents with probably a big burden, yet, the research and evidence that's coming from there is very minimal. But what does it mean for all people from those, originating from those areas that are across the globe in terms of evidence base? Because you can do good evidence work, but if it cannot be generalized to other populations, how do we expect those people to get better? And that's a big challenge. Most of my colleagues before me have talked about migration, the role of migration. I just thought I would just share a little bit about my England and the NHS. So the National Health Service in the UK is probably the 6th largest employer in the world. Some states will say probably the 7th. Obviously, interestingly, you've got the US defense being the first global employer. But I guess what's interesting is looking at how diverse the workforce is. You can see from the figure, largely the workforce is a migrant workforce. And this is a community that is actually holding the National Health Service. Once again, if you think about this inversely, you'll think about this is a population that is looking after the indigenous white community. And so when I talk about cultural adaptations and the work that we're doing, I just say, well, if this community of indigenous people were not culturally sensitive, didn't understand the British culture, guess what? The Brits are screwed. But that is the same thing that we're talking about to an indigenous white population workforce that is treating and/or should be treating people from the diverse communities. If you don't understand their culture, guess what? They're screwed. Once again, so this is not just the other type thing. This is something that affects both of us. Now, I think if we can learn anything from the conference, is that this is a dance. We're all in it. No one can dance on their own. We need to dance together. And to address this, we need each other to address this. So what is the role of migration? Once again, I'm not going to teach you to suck eggs. You already know this. Oftentimes, do we think about the risk, the danger that someone individual goes through from the country of origin? Now, imagine you leave your own country, whatever reason, war, trauma, everything else. You go into this alien place. The journey is fraught with danger. You see all this stuff on telly and everything else. But you get to this foreign place, you don't speak the language, the weather is different, and you're just stuck in this place where, you feel threatened, everyone else feels different, everyone else treats you and looks at you different. Just imagine the psychological trauma that you're going through, and you wonder why people become unwell. Once again, for us as healthcare professionals, do we explore the migratory stresses when we're doing our assessments? Do we even consider that as a factor? Because if we not, how are we formulating our interventions? Okay. There's always reasons why people migrate. In the UK, obviously people, if you think about the rhetoric, go back to your own countries. Why are you coming to a country? Oftentimes, the first migration, the Caribbeans, they were invited. They built the NHS. But is that what you hear from the media? Go back to your country? I mean, right now, we call it it's called the poaching. Some people use it of African intelligence when they say, get all the nurses away from Africa to come and work in the West. But yet, when you're there providing a service, being told, go back to your country, you're migrant. Do you understand the differences between the reason why people move and what the rhetoric that people say? And that's, once again, a miseducation and a misunderstanding that we often have to think about. How do we help people that misunderstand what goes on? So migration, its impact on mental illness. Our last census showed an ongoing increasing number of migrants, but equally, from healthcare, oftentimes, our patients, interestingly, Daniel was talking about, the silence, the silencing of the North Africa, the syndrome, the way that we treat it in the West is almost like, people get misdiagnosed and misunderstood. And oftentimes people get incarcerated and sectioned under Mental Health Act. And once again, is it actually because they've got a psychosis? Oftentimes people are being misunderstood and misdiagnosed and actually then put on medication. At the end, they end up becoming psychotic and all those things. It's similar. Now, we're using different words, but it's similar to that syndrome, still exists. And I've had, one thing that stuck with me was a Zimbabwean nurse who said to me, when I was being interviewed about my trauma, do you know what? I had to water it down because if I told them the full story, they would have thought I was lying and dismissed me. So again, similarities in themes. This is what people are experiencing all the time. People will just bring down what they're experiencing when you're asking them, because they think, well, if I tell you, you'll dismiss me. But these are some of the challenges. We see this through high rates of involuntary admissions. And interestingly, sadly, this is ongoing in the UK. Even right now, we're trying to deal with high rates of admissions in mental health sector within the Black British and the Afro-Caribbeans, to the point that the ONS at one point stopped recording the admission rates. But we also seen that the psychological needs were being less addressed through the care planning process. This is gradually improving, but we know that there are guidelines. I mean, we've got the NICE, you've got APA here, looking at things like, guidelines for schizophrenia, psychosis. Oftentimes people tend to go straight to medication, but actually, why not offer people psychological interventions? Why just give them high dosage of medication? So these are challenges that people are experiencing. And what can we do as healthcare providers to change this? And we know that, there is a lot of evidence on CBT, but as I say, the challenges are, if the evidence has been done on the other, how does it apply to the other? Can it be generalized? Okay. So then this brings the question, is there a case for cultural adaptations? When I started doing this work, my colleagues were like, oh, we treat everyone the same. We don't see color. If it works for so-and-so, it should work for so-and-so. Actually, there was a big pushback on why do you need to adapt something? It works, evidence is shown. You've got nice p-values and everything else. But, people do struggle. And, I know my colleagues have also referred to W.D. Du Bois and throughout the conference. One thing that he mentioned that has always stuck with me is a system cannot fail those who it was never meant to protect. So if you think about all the things that we've been talking about in this conference, life is smart. Okay, all the things that we've been talking about in this conference are, why are we having these challenges? It's because these systems were not created for us. And that's why they're failing us. They're not failing those it was created for. They're assessing health. Everything is working for them. But they're failing everyone that it was done for. And I think this is where we need to think about how to make that change. How do we engage the communities to understand what their needs are and to understand what works for them? And not just assuming that just because something works for our Western colleagues, it's going to work for the other. So what is the need for cultural adaptations? Once again, there's all these different dimensions which other colleagues have looked at: individualism versus communalism, differences in our cultures. Some cultures are very cognitivist, some are focused on emotion, free will and determinism, spiritualism, religion. One of the strongest coping strategies for most diverse communities. But yet, people don't talk about religion in some of the holistic part of the work. So once again, look at attributions of mental illness like psychosis. Amongst African colleagues, people assume supernatural experiences as well as wrongdoing for their past lives. Contrast that with colleagues within Asia and other areas, more around supernatural causes and as well as family stresses. And you see this when people give their attributions of mental illness. Now, they are not biopsychosocial, which means if they come and tell you that, I'm distressed because my neighbor has done NASA. Do you know what NASA is? NASA Lagana? Or someone come from the Caribbean say, he's done OBA? Huh? Yeah. So if I come and tell a psychiatrist that my neighbor has done OBA on me, this is why I feel this way, wouldn't you lock me up and just put me somewhere else? But guess what? That's what happens oftentimes to our colleagues. So what are some of the barriers? Once again, just look at some of them. One of the things I want to emphasize is, perceptions and attitudes of professionals. You are the gatekeepers. Oftentimes, your perceptions about can actually be a preventer or not. But also, the European civilized society, these assumptions, they resonate with a lot of people. Or you want me to think like you. Someone was saying, CBT, or cognitive restructuring, this was our black colleagues in London say, oh, you're trying to make me think like you people. Because they were talking about cognitive restructuring. So, you're trying to change my thinking so that I think like you. I was like, you have to be mindful, how do we convince people and change some of these things? But our illness models vary and differ. And it's very, very important to be mindful of this as well. Once again, key for me there is also lack of generalizability of a lot of our findings. Look at evidence-based, break it down by ethnicity. Look at, is it representative of the communities that you are trying to work with? And if it's not, that evidence doesn't apply. I think it's very important for us to be mindful of that. So the work around cultural adaptations, there was this study called the INSIGHT study. It was a large multi-center study done in the UK, which really had a significant proportion of participants from the Black African and Afro-Caribbean groups taking part in this study. Once again, at 3 months, the results were very effective. You could see the comprehensive psychopathological rating scale, schizophrenia symptoms, insight measured using Davis scale, and also burden and depression, all showed significant improvements. And at 12 months, once again, CBT versus TAU was effective. But when the results were broken down by ethnicity, what was interesting was, once again, comparing the white and Black Caribbean group and the Black British, there was significant high dropouts from the Black, African, and Caribbean groups, and insight did not improve. And that really got us to think about, why are these groups not improving? Why are the white counterparts doing well in CBT and the Afro-Caribbeans and the African groups not doing very well? And that really raised the issue around cultural adaptations. Might there be other things at play that we need to consider with our evidence-based interventions? Most of our evidence-based interventions are based from the West. They're based from Western concepts and theories. Now, all of you, you're trained on theories. Have you ever come across, Black psychology, Black theories and stuff like that? Are you taught those? No, you're not. So already your framework, which drives the process that allow you to think and function and frame the treatment that you provide, are already being driven by a westernized, whether it's American-centric, Eurocentric, whatever mindset. So even if someone comes and teaches you something on cultural adaptations, guess what? Your framework, all your psychological premises are already established. And then you've got cognitive dissonance. Well, the framework says this, the theory says this, the model says this, and it doesn't fit in, I'll go with the model. Once again, being mindful, this is some of our challenges. We see the world through our lens and cultures. Oh, it's another 5 minutes. Okay. Diversity, again, I'm going to teach you Psych X, cultural humility. You're going to have this. Very, very important. Obviously, once again, Tevlon and colleagues coined this term, but this is something that we've always probably been aware of and known. Cultural biases, understanding our limitations, but actively seeking to understand and appreciate diverse experiences. I mean, as for those that deliver cognitive behavioral therapy, CBT is meant to be we're meant to be curious practitioners, but do we provide humility? Are we open to other cross-cultural interactions, or do we come and impose a Western mindset to our patients? But something very important for us to think about. Once again, I'm not going to talk about this because my colleagues have already covered this area, but this is very important in CBT, especially when working with people from Black communities, oftentimes diagnosed with schizophrenia and psychosis. They'll come and tell you that someone's being racist to them. They just say, "Oh, it's your psychosis, mate." These are delusions. Now, one of my patients came up and said, "My neighbors are throwing stones at me. They're threatening me." And basically, they said, "Well, you're just being psychotic." And it only took, when I was invited to come in and do a home visit, that I came in, and once again, and this is where representation is very, very important. Some things, you don't have to tell me what's going on, I can see. Okay. And by just being there and asking what was happening, I was able just to separate the psychosis and what was happening. And it turned out, yes, they were actually throwing stones at his home. But it was coming out as people were saying, "Oh, it is just being delusional." Very, very important. Are you able to separate the illness from racism? If you're treating and you're stuck in therapy, is it because of your limitations in understanding those cultural nuances? Or are you saying, well, this doesn't work for this person? Once again, it's very, very, very important that we should recognize the potential of everyday racism and think about how we should be able to address that. Supervision becomes very, very important for us to consider and ensure that we've got, people that are experts in culture to really, really support us in scaffolding and developing our ways of helping our patients from diverse communities. So I'm probably not going to be able to cover all of these things, but I mean, we can see that, culture impacts psychosis basically from onset, psychopathology, all the way through to outcomes. Culture plays a part. And we've seen this through some of the historic studies like the empiric study, the ESOP studies. These were large studies that have looked at the impact of culture throughout, whether it's with the Afro-Caribbeans, you can look at the presentation of psychosis in the West versus in the country of origin. The way that you tell that is being highly diagnosed is you see that if you compare the country of origin, the rates are lower than in the West, where the rates are higher. But we also see genetics, they vary. Look at mothering styles. They vary across cultures. So some of the other cultural attributions to be mindful of, once again, colleagues have talked about discrimination, cultural norms, family dynamics, shame, guilt, all these things, they differ in how we deal with them across culture. Our help-seeking behaviors and pathways, amazing. People tend to think about, I'm going to go to healthcare as a last resort. Oftentimes within our own local communities, there's a multiple richness in terms of resources. For some, they'll go to the imams, they'll go to the mosques, they'll go to the gurus and leaders, and maybe at some point they'll decide, I'll go to this is my family doctor and others. Some actually fly home to go and get healed and exercise. I've had patients saying, okay, it's been sent home, and then when they come back, they're married. So what happened? Well, go get them married, give them some responsibilities and stop them from becoming distressed. This is what some families were doing. Once again, interest in understanding where your patients are and where they are. Once again, there's been some improvement in diagnostic criteria. They're now considering cultural sensitivity and other areas, some changes. Presentations vary across cultures, and each of the areas has got cultural themes. But what's always interesting for psychosis is the duration of untreated psychosis. It varies. Mainly, if you don't know, if you don't think you've got a psychosis, who's likely to refer you? If you're talking to spirits and other things people might not even think you've got psychosis. Once again, so these are some of the challenges. But also, somatization. Oftentimes people will say, well, people are somatizing, and for some, it's less stigmatizing to come and say, I've got physical pain and other things, but it doesn't mean that, if I come and tell you that I'm seeing my dead mother or voices and others are talking to me, you're more likely to, stigmatize me versus saying I've got physical pain. So once again, somatization is something that has been identified. But equally, our white counterparts somatize the same way. So there's no differences. I mean, literature and evidence has shown that. All right. So, okay. So I guess one thing that probably just, I think I borrowed this from Bernal when he said, one size does not fit all. But I think it's very, very important when we think about our interventions. Right now we're developing interventions, we think about communities, and I think yesterday someone mentioned 150, different, BSc communities here. So surely think about the interventions. You can't just have one intervention for all of them. I think it's important to think about what are other interventions that we can do. Obviously, if you do what Proscussion did, if you're short, it will stretch you, and if you're tall, it will chop you. Sometimes our interventions are that way. So, we've developed the adaptation guides, which once again, looking at, okay, how do I make an adaptation? Where do I start? Can I have 50 manuals of adapting? Probably not. But to adapt some of the work, so we've developed a framework of what really cultural adaptation is, and hopefully through conversations and stuff like that, I'll be able to share that. One last thing, I'll just quickly show you a slide that I wanted to show you. Sorry to say, just take you to one slide that I'm keen to share with you. So as we think about evidence-based interventions and adaptations, one of the things that I just wanted to quickly share is that we are running this Pan-African study, which is aiming at developing CBT, understanding the scope of CBT across the African continent. And for this study, what we're looking for is yourselves as healthcare professionals and clinicians, to really support us if you're working in psychology or psychologically informed work, to understand whether you've got an interest in supporting colleagues within the African continent, whether in supervision, training, research, grant writing, or publication. The reason why we're doing this as well is because currently the African continent is not represented in the global community of CBT. And this is the World Confederation of CBT. And so that you think of it, we talked about if you're not at the table, does anyone think about you? No. Yet we know this table is where people decide strategy and programs for supporting people from the continent. So what we're talking about is trying to encourage a development of a CBT association in Africa. And for that, we're asking for you guys to take part and support us in doing this. But also we're running the same study within the African continent to ask our colleagues what are their needs, do they actually want to be involved with European colleagues and global colleagues in this sphere as well. So this is what the Collabo study is doing. So please, I encourage you to join in and support both your African colleagues, but also some of you already might be working with colleagues there. If you're networking, do let us know what you're already doing. Thank you very much. So currently, I think I've got 3 people taking part in Canada, so I need more people to take part in Canada. So I think, Ottawans can do better, so I'll be looking forward to that. So thank you very much. And once again, please, please, please do know the populations you serve. There's now evidence for cultural adaptations, very good evidence, systematic revision and meta-analysis are showing that it's as good and even better than, and you'll have that in this slide set. But there are still gaps around the outcome measures that we are using. So we've adapted the interventions, but guess what? We're still using outcome measures that have not been adapted. That's where you come in as researchers. So we need you as researchers to begin to think about adapting and validating outcome measures that are sensitive to the population that we serve. And also to think about how we can scale and embed evidence-based, culturally adapted interventions across our communities. Thank you very much.
Voilà, Dr. Phiri, merci infiniment. What a wonderful and insightful presentation. And as you know, we have an exciting question and answer period ahead. Do not worry about the schedule. We know that we are off time, but it is important to do the important things in the moment. Yeah. So we'll take a few minutes and we have a mic that's going to be going around the room, but maybe I'll just get us started over here. You mentioned some of the challenges that people can have with regards to trusting, reporting their symptoms to the healthcare system. Either physical or mental health, we know that it all goes together. And if people feel like they have to downplay their symptom, or they have to sometimes exaggerate their symptoms to be taken seriously, how can individuals right now safely access the healthcare system without knowing if their healthcare provider is seriously going to culturally consider their symptoms, their realities? Thanks for letting us know.
No, once again, that's a very important question. And for us in the UK, as an example, the trust for services is very, very low. Whether there's a trust and also a satisfaction amongst the Black and Afro-Caribbean communities or people from the global majority is very low. And this is partly because of those problems that I talked about, being misunderstood, being misdiagnosed, and also people being incarcerated. But I think how we change that is once again beginning to, how do we understand our communities, going back to our communities, demonstrating that we are actually engaging them, but also we are listening to them when they're telling us what their problems are. How do you build trust? I think yesterday we were talking with Maya that, as a therapist or as a practitioner, it doesn't just because a doctor, you don't have to trust me just because I'm a doctor or in psychology. No, I have to earn my trust. And see, trust is not a guaranteed thing. Just because I'm wearing a white coat, or you're coming into my office, it doesn't mean that I've got to just trust you. Now, but imagine if you just told someone that you don't have to trust me. I'm going to earn my trust. But I also remind them that the time it takes, how long it takes for us to build that trust, will also impact the time that we're also able to have to do that. No. And I use something even simpler. If I could just for 1 minute, I notice some of you have got bottles on your tables, your water bottles. Yeah. Can I just do a quick experiment? Now, how many of you, when you broke the seal of your bottle, when you opened this morning, how many of you took a pH stick and tested the pH of the water? How many of you did that? Any hands? No. None. Okay. How many of you this morning crossed the zebra walking line at traffic lights when you said walk? How many of you crossed? Yeah. Okay. So when you turned green, you crossed. Did you hesitate to think, well, is the car gonna stop or anything like that? You just crossed it because it said cross. Okay. Most of you, when you walked in this morning and you came and sat on these chairs, how many of you checked if the chair could hold your weight? Anyone? So you did. Oh, there's one. Yes. Okay. So we've got one. But most of you did it. So you came in here, you trusted that this chair would hold your weight. So you might be asking me, Peter, why are you saying this and how is it relevant to trust? So, and I would say, well, you know what? even if you don't trust me as a service or as a clinician, let's start somewhere else. So I'll say, how much percentage do you trust the child could hold you? We say, well, I trust the university will make sure the repairs, blah, 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 50%, right? The water, well, this is authentic, 60%. So I'll say, okay, do you know what? So these are the people that you don't know, but yet there's almost like a degree of trust. Why don't we start somewhere else? So we start off, once again, at a level. It's never 0%. Even people that say, I don't trust, there's a percentage where they trust. You're just demonstrating that there's a degree of trust. And that is what then actually moves someone to say, okay, let's begin. And then you build that up. Same relationships are the same. You just fall into love with someone or you make them work for it. Any relationship is the same. So interventions for psychosis, especially schizophrenia, they are built on relationships. Trust is a key thing. Treating someone like a human being. Okay. Taking people at face value, not making assumptions, not jumping to conclusions. So when you say this, what do you mean? Can you tell me more? I'm curious, not just jumping into, oh, you're being paranoid and delusional. Thank you.
I think you partially answered my question. My question was, why is it, or have you looked to see why CBT works for some of us? What are some of the reasons why it works?
Okay. So, as I said, CBT is evidence-based. So, once again, it helps us understand the way our thoughts, emotions, and behaviors are connected within an environment. So actually, it works. Now, why it works for some of us and not for some of our communities is that, so, okay, most of us, if you are from a diaspora community, you will have migrated to your country to your host country. So you have left your host country and moved to your country of origin to your host country. And what you then do when you're in that country is you acculturate. So acculturating means you begin to engage with the community and begin to understand how the community works. And acculturation is a modality that really facilitates how much you are engrossed within the host culture's community, which means CBT, as an example, if you're in the Western culture, a lot of the things will begin to relate to you. So when someone is talking about things, it makes sense. So you don't have to adapt everything because some things you already understand. But there are those things that really don't align with that. For instance, your illness models. If you come from a culture where illness is caused by evil spirits, and someone is telling you it's in your brain, it's like no. I know something outside is coming. That's why I need something externally to come in. Because that's what people do. People actually say, give me a colored tablet because I know it's like your locus of control. If it's external, you want an external agent. A lot of times when people say, black people say, talking is our mantra. What do you think man talking is going to do, man? We talk all the time. But actually, because that's what people think. But actually, what is it about the talking that actually helps to change? And that's where the changes really come in. So adaptation is very, people from the first generations, they tend to be stuck to the culture of the country of origin, even though the culture in that country has moved on. Whereas the subsequent generations are more adaptable. So I would always encourage, if you're assessing someone and you're thinking about adaptations, do consider an acculturation scale, because that helps you to see how much adaptations you might need to do with that particular individual. For some patients, you don't need to make any adaptations because they are already acculturated. Hopefully, does that answer the question? Thank you.
I just have a question in terms of the government in the UK. I mean, it's a special case there. I was there last year. The NHS, at least these were the figures that they produced, that before pre-COVID, the loss in terms of the economy in the UK based on racial disparities and inequities, access to healthcare and so on, was in the £3 billion. But then post-COVID, that was almost tripled. But they're saying that in 10 years, this could be £300 billion. So the equivalent of building maybe 300 hospitals. So the problem is huge. But what is the government doing in order to bridge the gap? And it seems as though they're quite slow in bringing awareness together and putting money behind efforts. Apart maybe from the Scotland. Scotland seems to be going a little bit faster than England, for instance. But is there anything being done at that level to bring awareness?
Okay. So the differences, I think, between obviously Scotland and the UK is slightly, they're funded differently by the government. But in terms of psychological interventions, England has got the best funding that it was given to address some of the mental health burden. And this was the original access to psychological interventions, the IAP services. It was provided of 175 million across different governments, and that's been maintained. So that actually has injected over 12 million workforce of psychological well-being practitioners to really support the psychological work. So that's really, and I think it's been a biggest investment in psychology in addressing the burden of common mental health disorders. Now, with that, what that actually then did, it actually then facilitated access to psychological interventions for people from the Black and other communities in the sense that it allowed them to now self-refer rather than being told, come at this hour and at this hour. So which means people could self-refer, could access it online and other things in. So what we are beginning to see, an increase in other areas where really diverse communities are now accessing psychological interventions. But I mean, there's still a lot of work to be done, because the workforce is still not being represented, so which means some of those things are still being missed out. And I think one of the things that we've been pointing now is how do we really encourage people from diverse communities to apply to come and work in psychological interventions. So that's another challenge. Because once again, because of things like the West report and other things that says, well, Black people are being mistreated in the NHS and other areas, no one wants to come and work in there. But also there are challenges around people being promoted, so because they're not being promoted, which means it's not attractive enough for people to come in. So I think we've got two issues really. We need our communities to actually take part in training and also to contribute to the society around the workforce. And without that, we cannot. But funding has been punched in, and I think in comparison, I think a lot of countries would love their governments to give the same amount that the UK had, but it's always around the usage as well. So.
Dr. Phiri, everyone, applaudissez, applaudissez.